Yesterday, one of the oral presentations we gave here at ASH was focusing on genomic markers of resistance to the combination therapy of Daratumumab, Carfilzomib, Lenalidomide, and Dexamethasone, also referred to as Dara-KOD, which was published as an original paper in 2021. I was the lead author for the Manhattan trial that I designed when I worked at Sloan Kettering. So that therapy is extremely effective, probably the most effective therapy we have at the current time, but there are so many new drugs coming, so I'm sure that will be even better coming soon. But for now, I think it is probably the most effective therapy we have. We showed in the paper we published last year in Immuno-Oncology on the Manhattan trial that we could achieve MRD negativity in 71% of the patients. So this was in the absence of a bone marrow transplant. So these were unprecedented results. But still, there are 29% of the patients that were not MRD negative. And there were some patients that lost their MRD negativity over time. There are not that many that have lost their negativity, but 29% of patients did not achieve MRD negativity. And we have now follow-up information for a couple of years on these individuals. So we, here at ASH, took the baseline samples, we performed whole genome sequencing. We also performed single-cell sequencing on these samples from baseline. And then we had follow-up samples where we performed, again, whole genome and single-cell. Because very, very few patients, I think there were 1 or 2 that have had a relapse. Those few we could study with the whole genome, but we could do single-cell for all the patients over time and focus on the microenvironment. But for those patients who did not achieve MRD negativity, there were some patients that had signs of progressive disease. So we could then use these samples again to interrogate with the whole genome and single-cell sequencing. And what we show here at ASH is that the cells, they use certain defense mechanisms that make perfect sense. For example, you have genes that are correlated with expression, say, of CD38. And if you have mutations in those genes, that's why this therapy doesn't work, because it's a Daratumumab containing regimen. We also show that there are genes that are involved in the cereblon pathway. That's why the IMiDs don't work. So having a very well annotated cohort with high level information on the genomics has been instrumental for us in order to identify and do discovery work. But I also want to say that in addition to that, you need to have either functional studies or you need to have large validation cohorts, because how do you know that your results are really true? You need to always think about that when you design your studies. So we went back to the MMRF's COMPASS study, which is a fantastic asset. And we were able to replicate all our findings in that data set. And I thank, again, the MMRF for having set this fantastic study up several years back ago and to provide this for researchers like us so we can use it for validation of our discovery.